Hello, listeners, and welcome back to our podcast. Before we start today's interview, I wanted to remind you we're having our annual meeting in Las Vegas September the 1st through the 5th called Ortho on the Strip. We would love to see you there. Please sign up and register as the spots are going quickly. Listeners, welcome back where we continue a discussion with Catherine Sweeney regarding treatment updates on osteoporosis and sequencing of treatments. I recently contributed to an article on bone health in a publication called Community Health Magazine. We did a podcast on osteo several years ago with a PA named Catherine Sweeney, who's a colleague of mine who does bone health for my practice. And Catherine told me when I was asking her about the podcast that there are some new and exciting updates with treatments. Catherine, do you want to just jump in and start talking about medications?
Sure. So, with regards to osteoporosis treatments, we have lots of different choices now. We have two different classes of medication, one that we call our anti-resorptives, which stop further bone loss from happening. And we have another class called anabolic medications, which actually promote bone growth. The first group of anti-resorptives are our bisphosphonates, which you might be familiar with already. These have been around for many years and they are all generic. So that includes our alendronate, risedronate, abandronate, and zoledronic acid. The first three mentioned are pills, and zoledronic acid is an IV infusion. Abandronate also comes in a quarterly IV infusion, but probably not as commonly used as zoledronic acid. The other anti-resorptive we have is denosumab, which you might know as Prolia. This is an injection that's given every 6 months. And an update with this is the patent ran out this year. So we have two biosimilars that have been released in 2025 and expect about three others to be released later in the year. Biosimilars are not technically generic, they do have brand names, but they are made to be almost exactly like the original brand name medication. And then we have our anabolic agents, which include teriparatide, abaloparatide, and romosozumab, which is now our newer medication. Teriparatide and abaloparatide are both daily sub-Q injections that are taken for 2 years. And then romosozumab is a monthly injection that is taken for 1 year. So these are indicated in patients at high risk or very high risk for osteoporosis. And then finally, some alternative medications are ones that are a bit more related to hormones. Those include raloxifene, calcitonin nasal spray, and then, of course, hormone replacement therapy. None of these have quite the fracture risk reduction as the other medications mentioned, but could be an appropriate choice maybe for those even with osteopenia, trying to prevent osteoporosis, or those who may also be struggling with some menopausal symptoms.
So, great updates, similar to the past, but with a patent expiring, which is what I'm hoping will happen soon with some of the meds that I take. We have the biosimilars. So, have you seen equal effectiveness with your work, with the bone density studies, the DEXA scans and things? Have you seen adequate protection with these different meds, the biosimilars?
Yes, this is really brand new. So the first one just came out literally June 2nd, and the second one came out just a few weeks ago. I only have seen it in the studies. So I have read the studies that were done to gain FDA approval, and it does seem to be just as efficacious as denosumab. We're waiting on manufacturers and pharmacies and things to get them in stock. So the real world example will be to be continued. That can be on the next podcast, but the data so far does look equitable and promising.
Well, that's great news. How do you decide? What's your decision tree, Catherine? How do you decide what medications you're going to use? How do you pick what patient's going to have what? And, how do you make that decision? Is there an algorithm or something you go by? Just curious if you might share some of that.
Now that we do have all these choices, that's been a hot topic of research over the last couple of years is the sequencing of therapy and like you said, just deciding even initially who qualifies for therapy. There's been a new task force that was established last year through ASBMR and the Bone Health and Osteoporosis Foundation. They put out a new position statement almost a year ago exactly with this new concept of goal directed osteoporosis treatment, or you may hear it referred to as treat to target. This is a concept of kind of understanding the efficacy of these different medications and in reality, how much improvement you would expect to get from these medications. And then picking a medicine that would help get you to your treatment target in as little as time as possible. There's a lot of data out there showing improvements in bone mineral density with each of these medications and reduction of fracture risk. And some are a bit more efficacious than others. So when you look at your bisphosphonates, they're great as a first line, perhaps someone who has just been newly diagnosed, what we would classify as low risk or even moderate risk. But when we get into the classification of what we call high risk or very high risk, we may need to be a little bit more aggressive and pick a treatment that shows bigger improvements in bone mineral density to try to, at best, we are trying to get the patient at least to a bone mineral density T score of negative 2.5, or even cross the line into osteopenia, which would be a T score of negative 2.4. If you had a person with a starting T score of negative 3.7, let's say, in the spine, picking alendronate is probably not going to get that patient to your treatment target just because of the mechanism of action with only slowing bone loss, not promoting bone growth. So, in someone with that type of a scenario, we may need to pick an anabolic medication to get you to your goal. So, there are some guidelines and algorithms. The American Association of Clinical Endocrinologists, or ACE, we refer to, has published guidelines and they update them periodically. The last update was 2022 with the addition of romosozumab. And this kind of helps break down for providers who is in qualifies as low risk, moderate risk, high risk, and very high risk, and then breaks down what type of therapy may be best to initiate with.
Yeah, I was just reading through some of the notes. I do have one question. I want to back up for just a second with the bisphosphonates. Is there still any issue with the dental problems with the bisphosphonates?
Yeah, so there is a risk with the osteonecrosis of the jaw. Again, with the data we have, it has been documented to be more of a risk with long term use of bisphosphonates. So people who stay on them probably closer to 8, 10, 15 years. Thankfully, it's still a very, very, very low risk, especially compared to the risk of having a fracture if you didn't treat the osteoporosis. But the recommendation now, because of some of those side effects, is to take the medication for up to 5 years, reassess, and if things have improved or you feel like the patient is not at high risk anymore for fracture, then perhaps initiate what we call a drug holiday. But if the patient still is at significant risk after 5 years, you could consider continuing with a bisphosphonate or perhaps consider a switch to a different medication to help mitigate the risk of those long term side effects.
Well, what else do we have to talk about with sequencing? Any other updates with that, Catherine?
Yeah, so some nuances or updates again because we've now have all these choices. You really have a good opportunity as a provider now to tailor treatment to your specific patient with the the caveat or the reminder, that still, unfortunately, none of these medications are true permanent cures. So when someone is diagnosed with osteoporosis, we need to create that blueprint or that map of, all right, what is their treatment going to look like, especially since our anabolic medications are only given for a very finite period of time. So we need to have a plan then of what to do after that. With the data we have, the ideal sequence would be to start with an anabolic medication and follow with an anti-resorptive. And this is specifically more so for those classified as high risk or very high risk, which are patients who've had prior spine or hip fractures or low T scores below negative 2.5. Those patients, the data has shown you will get greater improvements in bone density if you begin with an anabolic medication and then switch when you finish that course of treatment to an anti-resorptive. A few little nuances. A lot of times patients will come to us for insurance or cost or whatever reason, have already been on an anti-resorptive. We sometimes then have to pivot a little bit and say, okay, they've been on alendronate for 3 years already and now coming to us, and now how do we optimize their bone health where they started with an anti-resorptive instead of an anabolic. When that happens, we do have some data that shows if you switch to teriparatide, you actually could get a decline in the total hip bone mineral density over the first few months. It does show, the data shows continued improvement in the lumbar spine bone mineral density, but you could actually see a decline when switching from an anti-resorptive to teriparatide. Now, we don't seem to see that decline when we make a switch from alendronate or bisphosphonate to romosozumab. So that could be something to keep in mind if we have a patient that we see for the first time who has already been on bisphosphonate therapy, but we feel like we need something different. Perhaps romosozumab could be a good option where we won't see that initial decline in bone density. Also, just a bit of sequencing recommendations that we know now with patients who do take romosozumab and denosumab. The effect of these treatments significantly drops quite quickly once those medications are out of your system. So, especially with romosozumab, it's important to have that game plan. When you finish your 12 months of therapy, you definitely need to go on something else for maintenance or continued improvement. There's also a lot of research out there now with how to successfully take someone off of denosumab if needed. And so far, the data has shown some promise with switching from denosumab to alendronate, as well as switching from denosumab to zoledronic acid. But just stopping denosumab and not taking anything afterwards, the patient could unfortunately see a quite rapid decline in bone density. There also is some good data, though, with using bisphosphonates very intermittently for maintenance therapy. So let's say we've got our patient, we did our anabolics for 2 years, we did maybe then a few years of zoledronic acid, and they're back up to osteopenia. They're doing good, the bone density is stable. There's actually been some good evidence then with using zoledronic acid, perhaps once one infusion every 4 years or even one infusion every 5 years just for maintenance. So again, we need to have that long-term plan, but there is a possibility for patients after they improve to take little holidays from treatment, but there are medications now that we can use a bit more long-term for maintenance.
That's great, Catherine. Thank you so much for the updates. Important. I mean, we've got 2 new drugs just within the last month, so that's great. What about the non-pharmacologic strategies? You mind touching base on that, the lifestyle changes and non-pharmacologic strategies for treating osteoporosis?
Absolutely, as the lifestyle portion is absolutely part of the holistic treatment plan. So, do we definitely need to be sure we're getting enough calcium and vitamin D, either through your food or supplements. The recommendations are approximately 1,200 milligrams of calcium per day and about 600 to 800 international units of vitamin D per day. Some people may need a little bit more, especially with regard to vitamin D, but I would base that based on lab work and current blood levels of the vitamins to know if you need more or not. Great sources of calcium from our food can be our dairy products. And a lot of the dairy alternative product now, like your almond milk or oat milk, cashew milk, all of those have calcium in them as well and are fortified with calcium. So even those who cannot tolerate dairy very well, that we now have some good alternatives in that regard. And then, of course, your green leafy vegetables are wonderful, and your broccoli, some bell peppers and figs, and even nuts like almonds and walnuts are great. Sunlight is certainly our greatest source of vitamin D, but in the wintertime or people who live in places where the sun is not as reliable, certainly taking a little extra supplement is a good idea. And then another really important part is the exercise, because the exercise is what tells the body that, hey, we're still being used. So we need to build more bone to support that use. And the exercises that send the strongest signals, are higher impact exercises or weight bearing exercises. So lifting weights, doing walking, jogging, a little jumping in place, resistance bands work is great. Body weight exercises are great. Even now, a very in vogue thing is walking with a weighted vest, but that helps because it puts a downward load or force on the spine itself to help promote that bone growth. Whereas going for a walk normally wouldn't really help your spine or your upper body very much with regards to bone density. But if you add a weight, the weighted vest or even a weighted backpack, you can actually incorporate the spine then and be able to stimulate bone growth there when you go for your walk. Balanced exercises are also very important because we need to stay on 2 feet and try to avoid those falls as much as possible. So, yoga is a great way to practice our balance, or even Tai Chi, and that will help then prevent those falls to minimize that risk of fracture.
That's great information, great updates, Catherine. A lot of exciting news with the new medication treatments, and we also have a lot of the old weight-bearing exercise and such. But any parting thoughts you'd like to share with our listeners?
Yeah, so I think it's a blessing now that we do have these choices. So, and certainly pros and cons with each, but I think this helps us as providers and clinicians be able to truly tailor our treatments for our patients and give them a little, reassurance that we do have ways now to actually improve their bone density and lower that risk of fracture and keep them active and independent and enjoying the things that they like in life. So certainly, risks and side effects have to be discussed, but now that we have these choices, for most everybody, there should be something that we can find to help them along the journey.
That's great, Catherine. Well said. And thank you so much for coming back today. We really appreciate your time, taking time out of your busy schedule and coming to record a few minutes with us. So, folks, Catherine Sweeney. Catherine, thank you so much.